Our next presenter is Dr. Nicholas Turner of the Royal Marsden Hospital in London, who will present GS304, capivasertib and fulvestrant for patients with aromatase inhibitor resistant, hormone receptor positive, HER2 negative advanced breast cancer, results from the phase 3 CAPItello 291 trial.
Thank you very much for the introduction. On behalf of my co-authors, it's a pleasure to present the primary results of CAPItello 291. Here are my disclosures. AKT pathway activation occurs in many hormone receptor positive, HER2 negative advanced breast cancers through genetic alterations in the pathway, but may also occur in cancers without those genetic alterations. AKT signaling is also implicated in the development of resistance to endocrine therapy. Capivasertib was developed as a potent selective inhibitor of all three AKT isoforms. And a previous phase 2 study, the FACTION trial, the addition of capivasertib to fulvestrant significantly improved both PFS and overall survival in the overall population, and with more pronounced benefit in pathway-altered tumors when measured in both tissue and liquid biopsies. The CAPItello 291 trial recruited patients with advanced hormone receptor positive, HER2 negative breast cancer, all of whom had progressed on a prior aromatase inhibitor. Up to 2 lines of endocrine therapy and 1 line of chemotherapy for advanced breast cancer was allowed. Prior CDK4/6 inhibitors were allowed, and at least 51% was required. And patients with diabetes not requiring insulin were allowed. 708 patients were randomized 1-to-1 to fulvestrant and capivasertib or fulvestrant and placebo, with the randomization stratified by the presence of liver metastases, prior CDK4/6 inhibitor, and region. Capivasertib was given 4 days on, 3 days off, a regimen selected early in clinical development to maximize the therapeutic window of AKT inhibition. There were 2 co-primary endpoints, PFS by investigator assessment overall, and in AKT pathway-altered tumors, which were those with at least 1 qualifying alteration in PIK3CA, AKT1, or PTEN. And the key secondary endpoints were overall survival and objective response rates. CAPItello 291 was designed to assess both PFS and overall survival. Focusing here on PFS, 542 PFS events were required in the overall population and 217 events in the AKT pathway-altered population. And this gave over 99% power to detect a difference overall and 91% power in the AKT pathway-altered, assuming a hazard ratio of 0.64. Hierarchical testing was employed in this study. PFS was tested overall at 3.5% alpha, and this was recycled to assess PFS in the altered population. And 2 further formal analyses of OS will occur in the future. Baseline and tumor characteristics were well balanced between the capivasertib and placebo groups, both overall and in AKT pathway-altered tumors. Overall, the median age was 59, 77% of patients were postmenopausal, and 37% of patients had primary endocrine resistance. Prior treatments were also well balanced between the groups. 69% of patients had had a CDK4/6 inhibitor for advanced breast cancer, and 18% of patients had had a prior line of chemotherapy for advanced breast cancer. AKT pathway alterations were assessed in tissue that was collected prior to randomization and analyzed with the FoundationOne CDX assay. Overall, 41% of patients had an AKT pathway alteration, and these were well balanced between the capivasertib and placebo group. As expected, the majority were PIK3CA alterations, but 4.2% had AKT1 mutations and 7.1% had PTEN alterations. 15% had an unknown result, predominantly because there was insufficient DNA for tumor sequencing after extraction. So we now move on to the two co-primary endpoints. First of all, we have investigator-assessed PFS in the overall population. Median PFS on placebo and fulvestrant was 3.6 months, and this increased to 7.2 months on capivasertib and fulvestrant, with a adjusted hazard ratio of 0.6, highly statistically significant, and you can see that the curves separate early and stay separated for the duration of follow-up. The second co-primary endpoint was investigator-assessed PFS in the AKT pathway-altered population. Here on placebo, median PFS was 3.1 months, and this increased to 7.3 months on capivasertib, with an adjusted hazard ratio of 0.5, again highly statistically significant. I show you here now an exploratory analysis of investigator-assessed PFS in the non-altered population that per protocol included unknowns, and here the hazard ratio was 0.7. Excluding unknowns, the hazard ratio was 0.79, with largely very similar curves. Now the forest plot of pre-specified subgroup analysis. Across all subgroups, there was broadly consistent efficacy of capivasertib. I highlight two. Patients with and without liver metastases had similar benefit from capivasertib, and also patients with or without prior exposure to CDK4/6 inhibitors also had very similar benefit to capivasertib. Response rates were assessed in patients with measurable disease at baseline. Overall, response rates on placebo and fulvestrant were 12.2%, and this increased to 22.9% on capivasertib. And in AKT pathway-altered population, response rate was 9.7% on placebo, and this increased to 28.8% on capivasertib and fulvestrant, with an odds ratio of 3.9. I show you here a planned analysis of overall survival that was requested by regulators at this time point to assess for no detriment. I highlight that there was no plan to assess for superiority at this time point. Hazard ratio overall was 0.74, and in AKT pathway-altered populations was 0.69. Now moving on to the safety. So in terms of all adverse events, any adverse event occurred in 96.6% of patients on capivasertib, and 82.3% on placebo. That included serious adverse events that occurred in 16.1% of patients on capivasertib and 8% on placebo. If we focus on adverse events leading to discontinuation, this occurred in 13% of patients on capivasertib and 2.3% on placebo. If we now look at individual adverse events that occurred in at least 10% of patients on capivasertib, the most common adverse effect was diarrhea, occurring in 72.4% of patients, predominantly grade 1, although 9.3% of patients had grade 3 diarrhea. There were two individual preferred rash terms, over 10%, and so we generated a group term of all terms of rash, and this occurred in 38% of patients overall, 12.1% of patients grade 3. But I highlight that the rates of hyperglycemia and stomatitis were low on capivasertib, and only 2% of patients had grade 3 hyperglycemia or grade 3 stomatitis. And so in conclusion, capivasertib plus fulvestrant provided a statistically significant and clinically meaningful improvement in PFS, both overall and in AKT pathway-altered tumors. Benefit from capivasertib was consistent across clinically relevant subgroups, including patients treated with a CDK4/6 inhibitor and patients with liver metastases. Overall survival follow-up is ongoing for the future planned analyses of overall survival, and the safety profile of capivasertib was consistent with previous reports, with relatively low discontinuation rates due to adverse events. And so capivasertib plus fulvestrant has the potential to be a future treatment option for this group of patients. We would like to thank in particular patients and their families who took part in the Capitello 291 study. And this QR code will access a plain language summary of this presentation. Thank you very much.
Thank you very much, Dr. Turner. Question from microphone 4, please.
Yes, Carlos Artiaga, UT Southwestern. Nick, thank you for your presentation. I know these patients were identified by next-gen sequencing of the primary tumor. What proportion had ESR1 mutations? Anything you can share about the response of those patients to capivasertib?
So we don't have that information yet, Carlos. I think it's clearly very important. So as you said, the majority of this was tested on archival tumors, including the primary, where the ESR1 mutations are not present. So a very important future biomarker analysis in this study will be the baseline plasma that's been collected for circulating tumor DNA assessment, and that is, of course, where we'll be able to look for ESR1 mutations.
Okay. Microphone number 5.
Eric Weiner, Yale. Nice presentation, Nick. Can you just comment on whether the toxicities, particularly the GI toxicities, improve with dose reduction?
Yes, so you refer predominantly to the diarrhea. Overall, this was actually fairly well managed by patients, so only 2% of patients stopped capivasertib due to diarrhea. It is predominantly in the time, the 4 days they're taking on the drug. It does get better with time, and certainly my own personal clinical experience of giving capivasertib, that it is relatively well tolerated by the vast majority of patients, but there is still a small minority who find the diarrhea difficult.
Thanks.
Okay. I'll ask a question. In the subpopulation of patients with PIK3CA mutations, do you think it would be a more appropriate control arm to have that be fulvestrant and alpelisib as opposed to fulvestrant and placebo?
Well, absolutely. So at the time we designed this study, fulvestrant was selected by, this was checked with the regulators and was felt to be the appropriate control arm for this global study, which also very much conducted after the onset of CDK4/6 inhibitors. And we also wanted to assess the overall population in this study.
Thank you. I think we have time for one more. Microphone number 3.
Barrios from Brazil. Great presentation, Nick. Thank you. Would you expect a larger difference between the two populations, the wild type and the altered population?
Well, look, it is clear that there's great efficacy of capivasertib in those tumors that have AKT pathway alterations. But similarly, it is also relatively clear that there's some activity of capivasertib in those tumors that don't have AKT pathway alterations, at least in their primary tumors. And so I think clearly this is a very important area for future biomarker research in the study to see if we can identify which of those patients with AKT pathway non-altered tumors are benefiting.
All right, thank you very much. Thank you again for an excellent presentation, Dr. Turner.